Let's talk about recovery after the TURBT. There's a lot of medications that we can give to help with recovery. What's your standard pathway? Do you have standard medications that you use or, to escalate in certain high-risk patients?
Yeah, we typically prescribe anticholinergics. We try to avoid anticholinergics in elderly patients due to the kind of dementia risk and constipation risk. So we'll use beta-3 agonists in those patients. Everybody goes home on Pyridium. We tell them to liberally hydrate, but that's kind of the basic package that patients, are counseled on and go home with postoperatively.
Are your patients typically getting pericath pull antibiotics for the Foley, or are there other medications that you use around that time?
Yeah, so we usually give education around. So first is like behavioral modifications while you're recovering, avoiding caffeine, citrus, spicy foods. We're borrowing a little from the bladder pain syndrome literature, right? So we talk about bladder irritants and trying to avoid those as you're trying to heal from surgery. I do talk about making sure you're hydrating enough. Also, that is for avoiding constipation, right? Because I do think that sometimes constipation definitely makes bladder symptoms worse, as well as hematuria after. I do warn patients that many will have another bleed. Usually when like the scab or tissue sort of falls off, it's somewhere around 10 days or so that it usually happens, 10 days to 2 weeks. So I do warn patients about that because I think it can be unsettling when all of a sudden you've been doing great for like a week and then there's like, it looks like a massacre in the bathroom, right? And so I do warn patients about that and then what to do in that situation. We use Pyridium to non-narcotic anti-inflammatories, Tylenol, ibuprofen if it's sort of safe. In terms of antibiotics, we do follow AUA's white paper recommendations. So a catheter in more than around 72 hours or more, we do give periprocedural antibiotics. If it's short, like you just need someone to have it for a day or two, we don't. And in those situations, I talk about beforehand if someone wants to learn to remove the catheter themselves. And then we have a nurse visit sort of scheduled around that same time we plan to do that so that someone can check in, because occasionally sometimes they want to, but they can't. And then we make the appointment in clinic. But that kind of helps patients coming from far away, or we can help set up appointments closer to home.
And how long is the antibiotic duration? I think the guidelines are not, super granular about that. Do you give one dose, 3 days, somewhere in between?
We usually give one dose in that setting. We'll alter based on prior experiences. So if someone had a real struggle with recurrent UTIs and those types of things, I may adjust and do day before, day of, day after, similar to like our stent pulls. But usually it's a single one, day of.
So Pat, you touched on this a little bit, but someone who's had many TURBTs before, are you able to predict who's going to have more issues after the procedure, and are you counseling those patients differently?
Yeah, going back to the original point, you gotta characterize the patient's prior experience with TUR. With bladder preservation comes lots of endoscopic procedures, biopsies, resections, lots of tiers and rounds of intravesical therapy. And all of these things are taking a toll on the integrity of the bladder, both storage and emptying function, right? I don't see that patients can objectively state that their bladder function is deteriorating with each additional resection or each additional intravesical therapy, but kind of taking a step back and holistically looking at a patient's bladder function and pain and symptomatology, it does kind of deteriorate over time, and you have to counsel patients on that. Most patients are highly interested in bladder preservation, and that comes at a cost of these repeated procedures and treatments that can weigh on bladder function.
Yeah, I've anecdotally found that if you do a big TURBT on a patient who's had many procedures before, sometimes it really is a much bigger recovery, and it takes months for them to get back to their baseline.
Yeah, and back to your point about kind of trying to resect all CIS or doing kind of a heroic TUR in a potentially unresectable tumor, that you're going to push that patient towards a cystectomy pathway, whether they like it or not, because they're going to end up with a highly fibrosed bladder without any capacity, and so there's a fine balance there.
I think this is going to be our next sort of research or study focus, right? Because now that there is a possibility to do bladder preservation, I think the question is how can we improve patients' experience through it, right? I think in cystectomy, that conversation started probably like 10, 15 years ago when I was in fellowship with enhanced recovery after surgery. That was like the big thing happening, and working on patient education prior to it. And I think we're probably going to see a change in research, and you're already seeing it in the type of publications. And I know you have a lot of interest and work in this for TURBT and these intravesical therapies and procedures. How do we improve quality of life on that? And I think it does, we see that a little bit in the cysto study, right? And the results of that were surprising, that patients who underwent radical cystectomy actually had a pretty great overall, in the end, quality of life from that perspective. But to me, when I looked at that, I was like, okay, kind of makes sense, but it means that for us, for our community, we probably have to do better at paying attention to and managing and hopefully maybe mitigating some of these side effects. I don't know how to do that right now, but I think that is going to be a really interesting research focus kind of in the future. Particularly that kind of goes with what's happening in medicine in general and some of these regenerative sort of therapies, techniques, etc.